This program is brought to you by Emory University.
Okay, good morning. Thank you for being here. As you can see, well, you can't see because her name actually isn't on the title slide. But as you can see from her presence, those that are in the room, Bianca Yoo is our speaker this morning. Bianca is a second-year fellow in our clinical track. She did her undergraduate studies here at Emory, then went to University of Vermont for medical school. And the coffee just arrived. Good news. So feel free to get coffee as we get going. She went to University of Vermont for medical school and then University of North Carolina for her residency. And it looks like she's going to talk to us about, she's inventing new subgenres of cardiology. She's going to talk to us about cardio-rheumatology today. Bianca.
Thank you. Hi, everybody. So we're going to talk about cardio-rheumatology today, and specifically, we're going to talk about the increased cardiovascular risk, the increased risk of cardiovascular disease in patients with chronic inflammatory diseases. And this topic is important because I guess I didn't realize how important it was to pay special attention to this population until I actually did some research on it. I did a paper with Dr. Izzy Denzo, and it opened my eyes to how I can't treat patients with rheumatologic conditions, or I can't think about them quite the same as I do the general population. So I know it might not be as up and coming as some of the other topics, but I do hope that you guys take away from this talk some of the differences in patients with chronic inflammatory conditions, and maybe learn something or two. Okay, so I have no disclosures. Objectives: we're going to discuss the increased risk of cardiovascular disease in patients with chronic inflammatory diseases, and we're going to go over some literature that demonstrate this increased risk for morbidity and mortality, and go over the pathophysiology of accelerated disease in these patients. We'll review the utility of risk factor calculators and imaging in the specific population, and we're also going to explore the role as cardiologists in patients with chronic inflammatory diseases. So the takeaway points for this is that patients with chronic inflammatory diseases are pretty complicated. They have a lot of comorbidities, and they're also high-risk patients due to the comorbidities. They're also high risk for developing cardiovascular disease. So the increased risk for cardiovascular disease in patients with chronic inflammatory conditions, particularly RA and SLE, is pretty well established in the literature. We've known this for a while. Worldwide, so these conditions are estimated to affect up to 3% of the population, with RA being the most popular, affecting 1% of the population. Studies demonstrate that rheumatoid arthritis is associated with a twofold increased risk of myocardial infarction, and a threefold increased risk of cardiovascular disease. And we're going to take a more in-depth look into this research in a little bit. Similarly, patients with SLE have a more than sevenfold increased risk of coronary heart disease and stroke, and a 17-fold risk of death from coronary disease, even after controlling for the traditional risk factors. So while certain inflammatory conditions are associated with coronary arteritis, premature atherosclerosis underlies the majority of these coronary events. So it's not just coronary arteritis that causes this accelerated disease. It's premature atherosclerosis that's really the driving force under this. So patients with rheumatologic diseases may not have significant atherosclerosis on angiography, but these autoimmune conditions could aggravate lesion inflammation, thereby rendering plaques more vulnerable to rupture and thrombosis. And it's not only atherosclerosis that puts these patients at increased cardiovascular risk. Things like myocarditis and other non-ischemic causes of heart failure also contribute. So let's review some of the literature, and it's important to note that a lot of the clinically relevant studies done on patients with chronic inflammatory diseases look at rheumatoid arthritis and then SLE next, since they're the most common conditions. But it's also important to note that both of, all these inflammatory conditions do have significant burden on patients' health and quality of life. So a lot of literature I'm going to review today will be on studies that include patients with RA and some with SLE, but please keep in mind that there are several other inflammatory conditions out there, and not all of these conditions behave the same with respect to risk and cardiovascular disease. So one retrospective cohort study looked at the risk of clinical coronary heart disease in patients with RA compared to age and sex matched subjects without RA to determine whether RA is a risk factor for coronary heart disease after accounting for traditional CHD risk factors. The authors compared 603 RA patients with 603 age and sex matched non-RA patients. And of note, they reviewed the subject's medical records beginning at 18 years old. So they went through the EMR and they looked at both inpatient and outpatient medical records beginning at 18 years old. So they're able to look at events even before RA diagnosis. They collected data on traditional risk factors, including diabetes, hypertension, cholesterol, BMI, smoking status, and they collected data on coronary events, which included hospitalized MI, unrecognized MI, coronary vascularization events, angina, and sudden deaths related to coronary disease. So in the 2 years prior to RA diagnosis, patients with RA compared to patients without RA were more than 3 times more likely to have been hospitalized for acute MI with an odds ratio of 3.17, and they were more than 5 times likely to have experienced a silent MI with an odds ratio of 5.86, even after adjusting for the CHD risk factors. And then in this study, the silent or unrecognized MIs were defined as the presence of characteristic EKG findings in the non-acute setting or recorded physician diagnosis of characteristic EKG findings for without a documented history of MI. So these results are important because it shows that at the time of RA diagnosis, these patients already had manifestations of their increased cardiovascular risk. So they are experiencing the sequelae from cardiovascular disease even before the diagnosis of RA. After the RA diagnosis period, RA patients represented here in the dark line, the dark solid line, were still twice as likely to experience unrecognized MI. So the hazard ratio here was 2.13. And so over here, time 0 is the diagnosis date. And on the x-axis, we have years since the index date, and on the y-axis, we have cumulative incidence. RA patients in the same study also demonstrated a 2-fold increased risk of sudden death with a hazard ratio of 1.94, and they also reported less angina than their non-RA peers, which was a case for when looking at patients prior to diagnosis. They also reported less angina than their non-RA peers. And so I think this shows that patients with RA have atypical symptoms because, clearly they had more unrecognized MIs and more death related to coronary events. So it's likely, that this atypical pain that they're probably having is an important factor. So another study looked at outcomes after MI in patients with RA compared to patients without RA. And this study showed that patients with RA have poorer long-term outcomes after MI. Specifically, RA patients were found to have a higher rate of mortality following MI despite similar revascularization and cardiac medications. And the standard mortality ratio is 1.47. In both groups, earlier deaths were predominantly cardiovascular, and later deaths were predominantly non-cardiovascular. There was no significant difference in the proportion of deaths due to cardiovascular causes. Also, RA patients were more likely to have recurrent ischemic events compared to their non-RA peers. Then there was another study that looked at the impact of RA and SLE on the outcomes in patients undergoing PCI. So in this study, they identified 171,547 patients who underwent PCI for the first time between 2000 and 2010. 525 had the diagnosis of RA, and there were 211 patients in the study that had the diagnosis of SLE. And the authors looked at overall mortality and adverse cardiac events. And so that includes ischemic events, repeat revascularization, and basically MACE. So in this next slide, I apologize because I tried to keep everything color coded. I tried to keep RA red and SLE blue, and then I put this study in, and the colors were flipped. And I was, as like somebody who's like a little OCD, I was just like so angry. I almost went back and changed everything, but I was like, no, because I was like RA begins with red, or RA begins with R and it's red. So yeah, so I apologize. So this one's a little off, but but I just wanted to sort of acknowledge that. So bear with me and do the color swap for this slide. So during the follow-up period, both RA, represented as the blue line, and SLE, represented as the red line in this case, were associated with increased overall mortality and major adverse cardiac events. Oops, okay, let's see, there we go. SLE had increased association with repeat revascularization. And what's interesting is that there was a difference between the risk of repeat revascularization associated with PCI, but not before 4 years. So there was no in the SLE cohort. There was not significant difference, but after the 4-year mark is when the SLE cohort showed that they had increased risk of repeat revascularization. So that was kind of interesting about this study. And then during the follow-up period, RA was associated with increased ischemic events after PCI, though the association was not as strong as some of the other variables looked at in the study. And additionally, the inpatient hospital mortality rates of both RA and SLE after PCI were higher than controls. So while still inpatient after PCI, controls had a 2% mortality rate, whereas in SLE patients, 4.2% of those inpatient after PCI died, and then in the RA population, 5.2. So controls had 2, SLE patients were 4.2, and RA patients had a mortality rate of 5.2. So definitely there was a higher rate of inpatient mortality status post PCI. SLE patients showed a difference too, in that in SLE patients, recent SLE-related hospitalizations were associated with increase in hospital mortality after PCI, whereas in patients with RA, recent RA-related hospitalizations were not associated with increased risk of mortality after PCI. So again, showing that these patients, even though they both have chronic inflammatory conditions, there are differences in their disease processes. So these studies remind us that patients with chronic inflammatory conditions have inherently increased cardiovascular risk and require special attention from providers with regard to primary and secondary prevention. So I put this slide in just to, one's a Humira ad. She probably does not really have an inflammatory condition, but you see that, these patients, a lot of them are young, they want to live their lives. And then on the bottom, I put some celebrities that have some sort of chronic inflammatory disease. So Madonna has rheumatoid arthritis. She says that it sometimes affects her dancing. I don't know how much she dances anymore, but she said that sometimes she has to take a little slower because of her rheumatoid. Seal has lupus, so hence the reasons why he has the scars on his face. But he is someone who suffers from lupus. And then Selena Gomez also has lupus, and she actually is status post-renal transplant a couple years ago. She ended up having renal failure and got a transplant. And so she certainly has a sequelae of this inflammatory condition. So we'll briefly talk about pathophysiology. It'll be short. It's only like 3 slides, so bear with me. And I put this little cartoon in just to remind us, because I'm talking a lot about RA and SLE, but gout is also an inflammatory condition. So just reminding you guys that there are a lot of other inflammatory conditions out there, and some of them we kind of take for granted. So gout, everybody has gout. Like all our patients on heart failure have gout, right? Because we give them gout flares and we give them 200 IV Lasix BID. But I wanted just to remind you that gout is also an inflammatory condition. So pathophysiology. Normal endothelial cells are tightly joined and are impermeable to large molecules. So in the absence of inflammation, they produce antithrombotic molecules and are able to modify smooth muscle contraction with the release of vasodilators and vasoconstrictors and resist leukocyte adhesion, thus combating local inflammation. So it's when these leukocytes adhere to the endothelial cells, and if they're not tightly joined in the setting of inflammation, these cells can seep through and hence cause accelerated atherosclerosis. So even in the setting of early atherosclerosis, the activated endothelial cells both respond to and produce vasoactive agents such as IL-6 and TNF, which result in leukocyte adhesion and infiltration. Monocytes then penetrate the intima and eventually form foam cells, which further propagates the inflammatory cascade. So this is all stuff that's happening in the general population. All of our patients, this is the pathophysiology of atherosclerosis. But in our patients with chronic inflammatory diseases, they have an extra hit. So this immune dysregulation seen in patients with chronic inflammatory diseases further enhances this whole process. And while chronic inflammatory conditions often predispose patients to premature atherosclerosis, the pathogenic mechanisms are different from disease to disease. So for example, in RA, TNF-alpha, IL-1, IL-6, those all play important roles in the pathogenesis of accelerated atherosclerosis, whereas in SLE, type 1 interferons are the most important. Additionally, patients with RA showed decreased levels of endothelial progenitor cells, and these cells regenerate vascular endothelium and are inversely related to cardiovascular risk. Thus, the decreased level in patients with RA suggests an impaired ability to repair endothelium. The role of autoantibodies, either as biomarkers for cardiovascular disease or as accelerants of cardiovascular disease, is not yet entirely clear, and it certainly presents a big area for future research. So there have been some associations with biomarkers and endothelial dysfunction and plaque development. However, no concrete pathological link has been shown at this point. And additionally, since our patients with chronic inflammatory diseases also participate in the average American lifestyle, they often have the traditional risk factors associated with vascular disease, so hypertension, diabetes. A lot of them are smokers. A lot of them are sedentary. So it's an extra factor that will, of course, lead to atherosclerosis. Certainly, we have a hard time enough in our general population controlling this disease. So when you add in all of this stuff, you can appreciate the accelerated disease. So how does all this play out in our clinical practice? As we mentioned, traditional risk factors here contribute to cardiovascular disease and chronic inflammation. And these are all the traditional risk factors that we just talked about. But patients with chronic inflammatory diseases should receive aggressive counseling and management for their cardiovascular risk factors. So hypertension, it's very common in the general population, and we see it in almost all of our patients in clinic. But often the medications used to treat chronic inflammatory diseases, such as glucocorticoids and NSAIDs, make hypertension even more difficult to manage. Hypertension is highly prevalent in RA. However, it is underdiagnosed in the younger population. So in this slide here, you can see, this should be orange, but these younger patients, there's a lot more of them who are underdiagnosed, who aren't diagnosed with hypertension, even though they actually do have it. The authors of this paper didn't go into a lot of detail as to why young patients are underdiagnosed, but it could be due to the fact that younger patients are less likely to seek out preventative care. I've even heard some of our own cardiologists ask, do I really need to see a doctor before the age of 60? So younger patients are less likely to actually go to seek out primary care, preventative care. Providers may also shrug off elevated blood pressure in a setting of pain. So, how often do you have patients that come to clinic that have, a flared up back or flared up knee, their blood pressure's a little high, and sometimes, as opposed to starting another medication and being aggressive about their blood pressure, we might just, sort of shrug that off due to, they're in a lot of pain today. That's probably why their blood pressure is so high. Check your blood pressure at home. Call me, if it's elevated, which patients often don't do. Similarly, hypertension was undertreated in patients who were older. So older RA patients were undertreated, and so you can appreciate that here. So I highlighted that in orange here. And this is most likely due to suboptimal therapy or medication non-adherence. So suboptimal therapy, there are a lot of older patients, we run into a lot of complications with low blood pressure, not wanting to cause too many problems. They have a lot of comorbidities, so it's harder to add on an extra antihypertensive to get that extra control. And then on top of that, older patients, in that population, we have more issues with medication adherence. One, because they're already on so many medications, it's hard for them to manage all of them. Two, a lot of them have cognitive issues. A lot of them also have, especially people with chronic inflammatory disease, might have issues with opening all the bottles and require a lot of extra assistance with managing pills. So that's another reason why you see non-adherence in this population. And again, that's probably why older patients with RA just don't have as good of control over their hypertension as the general population. So this led authors to conclude that aggressive strategies for screening, treatment, and monitoring of hypertension is required in the RA population, which is, oh, sorry, I'm going the wrong way, which is all common sense. I know, obviously, like, you want to have aggressive screening strategies in these patients, but I think it's harder to do in clinical practice. It's easier said than done because of the barriers that we mentioned before. And while not considered a traditional risk factor for CAD, obesity is related to several traditional CAD risk factors and markedly increased mortality in the US. Moreover, patients experiencing excessive morbidity from disease related to obesity, so they might have diabetes, hypertension, and cardiovascular endpoints such as MI, stroke, and heart failure. Obesity also tends to be higher in patients obesity can also cause other health conditions too, or be related to other health conditions such as asthma, cancer, sleep apnea, and painful osteoarthritis. So all of these things that we talked about are associated with obesity. Providers, so we commonly prescribe routine physical activity to combat obesity and promote a heart-healthy lifestyle. However, the sequelae of chronic inflammation of joints has led to decreased physical activity in patients with CID. So this physical inactivity further perpetuates some of the other things we talked about, like diabetes and more obesity. So this is a hard situation for these patients because a lot of times the patients with chronic inflammatory conditions have a harder time exercising because of the pain associated with their joints. But certainly all of these risks and sequelae from obesity are clinically relevant. To complicate things even further, low BMI has a paradoxical effect on cardiovascular risk in patients with RA. So remember that cohort that we used to predict coronary disease in patients with RA a couple slides ago? The authors used that same cohort to evaluate the relationship between BMI and cardiovascular mortality in patients with RA. And they found that in patients with RA, low BMI is associated with a significantly increased risk of cardiovascular disease, even after controlling for personal cardiac history, smoking status, the presence of diabetes, hypertension, and malignancies. So looking at this figure, BMI is grouped as low, medium, and high, as plotted against hazard ratio for cardiovascular death. And the patients with RA and low BMI had a threefold increased risk of cardiovascular death when compared to non-RA patients with a normal BMI. However, in patients without RA, and a low BMI, they did not have increased risk for cardiovascular deaths when compared to patients, non-RA patients with a normal BMI. So a possible explanation for this is that low BMI could be a marker for poorly controlled systemic inflammation. Because like I said, we don't expect to see this. We don't expect to see people with low BMIs to have this increased cardiovascular risk. But in the setting of patients who have uncontrolled rheumatoid, perhaps this could be a marker for poorly controlled systemic inflammation and accelerated atherosclerosis. With regard to SLE, there have been multiple studies suggesting that high BMI is associated with disease activity. There have been a bunch of studies that have said that, but there was also one small Korean study which demonstrated that low BMI was associated with thickened carotid intima. So again, this just shows that the patients, we can't look at these patients through the same lens that we look at our other patients. And as cardiologists, we tend to focus on obesity. We tend to focus on weight loss when making medical management decisions. But we also have to pay close attention to patients with chronic inflammatory conditions that have low BMI or are losing weight, because these might be red flags that these patients aren't doing well. Let's see. So again, as cardiologists, we all know the detrimental effects of high cholesterol in the general population. So hyperlipidemia is a well-established risk factor of coronary disease. However, in patients with RA, there is a paradoxical effect of lipids on cardiovascular risk, whereby lower levels of cholesterol, of total cholesterol and LDL, are associated with increased cardiovascular risk. So on this graph, we have total cholesterol plotted on the x-axis, and hazard ratio for cardiovascular disease is on the y-axis. And notice that at the lowest levels of total cholesterol, you see the highest CVD risk. So the authors took this study a little further, and they looked at the impact of active inflammation on lipid levels. So in this graph, you see ESR is plotted out on the x-axis, and the hazard ratio for CVD is, again, on the y-axis. So at low levels of inflammation, excuse me, at low levels of inflammation, i.e. low ESR, the risk for cardiovascular disease and lipid ratios are similar to what we see in the general population, meaning the patients with total cholesterol to HDL ratio of 6, which is the dotted line, they have the highest risk of CVD in patients, they have the higher risk of CVD when compared to patients with a total cholesterol to HDL ratio of 2, which is represented by that light gray line. However, at higher levels of inflammation, this relationship is flipped. So at higher levels of inflammation, patients with a total cholesterol to HDL ratio of 2 have higher risk for CVD, and the patients with a total cholesterol to HDL ratio of 6 are associated with a lower risk of CVD. So the reason for this paradox is not entirely clear. There is some thought that lipids might confer some protective effect on modulating autoimmune and inflammatory markers, or that systemic inflammation may have a cholesterol lowering effect, but still cause a lot of vascular inflammation to propagate atherosclerosis. Furthermore, patients with RA and SLE have been shown to have increased levels of abnormal pro-inflammatory HDLs, which promote LDL oxidation and formation of foam cells. So in patients with RA and SLE, their HDLs are not the same as ours. They actually are pro-inflammatory HDLs that further accelerate atherosclerosis. So again, that just all stresses the importance that we just have to look at these patients differently. We'll talk a little about anti-inflammatory medications, and as mentioned earlier, medications used to treat chronic conditions can affect the parameters associated with cardiovascular risks, not to mention the side effects that affect patients' quality of life. So these are all real quotes from patients taking prednisone. My favorite is, "I could bite the nose off a grizzly bear and then cry for a week because I hurt him." So that just made me wonder, what would a pregnant person on prednisone be like? It's scary. If you're craving pickles and can't get the jar open, it'll leave you crying in the kitchen. Only someone with prednisone would understand that cake and bacon taste better at 3 a.m. I think people not on prednisone can understand that too. And then prednisone on 60 milligrams, someone on 60 milligrams of prednisone knows what it's like to scrub your oven with a headlamp 2 o'clock in the morning. So really, prednisone we love to use it as providers, but patients sometimes can have a hard time tolerating the side effects from prednisone. So glucocorticoids contribute to insulin resistance, increased blood pressure, weight gain, and dyslipidemia, all which negatively impact risk profile. However, there is some evidence to suggest that in certain subgroups, these anti-inflammatory effects of corticosteroids may provide cardiovascular risk by mitigating systemic inflammation, thereby reducing smooth muscle cell proliferation and ischemic tissue injury. Similarly, NSAIDs at high doses or when chronically used contribute to hypertension and can acutely impair renal function. This is of significance in SLE patients with renal complications. Chronic kidney disease can further promote atherosclerosis, and while more research is warranted, one study showed that NSAIDs related to cardiovascular risk in RA patients was modestly increased compared to non-RA patients, while another study demonstrated that patients with inflammatory arthritis, NSAIDs was not associated with increased cardiovascular risks. So this topic, again, is not cut and dry. We know that NSAID use is associated with increased cardiovascular risk in our general population, but it's not entirely clear how this affects risks in our patients with chronic inflammatory diseases. Like what outweighs, what tips the scale? Is it the systemic inflammation, or is it the cardiovascular effects of the NSAIDs? Calcineurin, so more inflammatory drugs, calcineurin inhibitors, such as cyclosporin, are associated with increased risk of diabetes and hyperlipidemia. And on the contrary, evidence suggests that methotrexate, which is a long-standing RA medication, improves cardiovascular risk by way of decreasing systemic inflammation and subsequent progression of atherosclerosis. We're going to go into risk calculators a little bit. So our traditional risk factor or risk calculators, such as the Framingham, Reynolds, risk score, ACC, the ASCVD, they all underestimate the risk for cardiovascular disease in patients with CID. These calculators were made for patients in the general population. However, we know that the impact of certain risk factors differ between patients with and without chronic inflammatory diseases. So we can't necessarily apply the same risk calculators to our patients with inflammatory conditions as we do our general patients. So how well does the Framingham do in patients with RA? It's interesting that patients with RA, in patients with RA, the presence of RA seromarkers, so rheumatoid and rheumatoid factor and CCP, these seromarkers influenced how well the Framingham risk score predicted cardiovascular disease. So in patients with RA who were seronegative, meaning they did not test positive for rheumatoid factor or CCP, the Framingham risk calculator did a pretty good job at predicting 10-year cardiovascular risk. So in the dark line, that is the observed risk, and the dotted line is the predicted risk. And so you can see in men, it did a great job at predicting seronegative men. It did a great job predicting cardiovascular risk, but in women, it did a pretty good job. It was a little off. It underestimated it by a little bit, but overall, it did a pretty good job at estimating 10-year cardiovascular risk in seronegative patients with RA. There we go. However, in seropositive patients with RA, the Framingham risk calculator does not perform well in predicting cardiovascular disease. So again, the solid line represents observed, and the dotted line represents the predicted. And here we see that in these seropositive patients, the observed is a lot higher than predicted. So there's something about actually having these positive markers that do confer increased inflammation and accelerated disease. And certainly in these patients, using a regular risk calculator would likely underestimate the risk in patients. So while the ACC and the AHA risk estimator, so ASCVD, underestimates risk in patients with chronic inflammatory diseases, It does identify inflammatory disease, so RA, SLE, psoriasis, HIV, as risk-enhancing factors. So notice that there are other risk-enhancing factors. So out of this whole list, looking through it, there are a lot of other risk-enhancing factors that are prevalent in our patients with chronic inflammatory diseases. So metabolic syndrome, CKD, especially in our patients with SLE. So recognition of these risk-enhancing factors should prompt clinicians to further consider and discuss cardiovascular risks in these patients. The problem is that there are no validated calculators and there are no loud and clear guidelines for these patients. So at this point, these patients rely on providers to use clinical judgment and engage in conversations and really tailor their treatment plans towards the patient. So what do other groups do? The European League Against Rheumatism, or EULAR, they recognize that patients with inflammatory conditions have increased risk for cardiovascular disease. So they recommended multiplying cardiovascular risk prediction scores by 1.5 in certain patients with RA to adjust for their increased cardiovascular risk. The multiplier is applicable to patients that have two or more of the following: either disease duration of greater than 10 years, RF and or ACPA positivity, and the presence of severe extra-articular manifestations. There was another group that took this one step further. They recognized that multiple chronic diseases such as CKD, diabetes, and inflammatory diseases like RA have increased cardiovascular risk, and that traditional risk calculators underestimates risks in these populations with some of these chronic conditions. So they made the Q-Risk3 risk calculator, which again was another predictive algorithm for cardiovascular disease commonly used in the UK that uses traditional risk factors, so age, systolic blood pressure, smoking status, HDL, LDL, much like the ASCVD. But they use that together with BMI, ethnicity, family history, AFib, CKD, antihypertensive treatments, and they also included rheumatoid arthritis in there as one of these other chronic conditions that increases risk. So they included rheumatoid status in their risk calculator to help augment cardiovascular risk assessment. There was another group that took this even further, and they created a risk calculator that was specifically designed for patients with rheumatoid arthritis. So the expanded cardiovascular risk prediction score for RA, risk assessment tool, or the ERS-RA, incorporates RA disease characteristics into their algorithm. This tool augments traditional risk factors with information on RA disease activity, disability, corticosteroid use, and disease duration. So it uses traditional risk factors in conjunction with these RA-specific disease findings, and it calculates a score based on this. And this was a unique risk calculator because it was made specifically for patients with RA. So how did these risk calculators play out? There was some promising preliminary evidence of their utility on internal validation, but one group sought to externally validate these risk calculators. So 7 RA cohorts from the UK, Norway, Netherlands, US, South Africa, Canada, Mexico were all combined and looked at, and the performance on these adjusted risk calculators were compared with ACCHA, Framingham, and Reynolds risk score. Unfortunately, despite the inclusion of RA-specific risk factors, the ERS-RA, Q-Risk3, and EULAR 1.5 multiplier, they actually did not improve cardiovascular risk predictions for patients with RA compared to the general population, with general population CVD risk calculators. So ERS-RA had comparable or lower estimates of cardiovascular disease. The Q-Risk3 and the EULAR 1.5 multiplier actually had higher risk of cardiovascular disease estimates. So these risk calculators, they aren't ready for prime time. However, the authors did note that that these RA-specific calculators could perhaps be useful in certain subgroups of patients with RA, but we just have to identify those, and that will take more studies. We'll talk a little bit about imaging. I'm on nukes right now. This is kind of how I feel. Yesterday, this is exactly how I felt. I was like, oh my gosh, like I'm just sitting all day. I had to get like a wound consult once I developed my sacral ulcer. But But yeah, so somebody actually had a positive stress test, and I got really excited because I got to leave the room and like go see a patient. So that was exciting for me. I keep going the wrong way. So imaging. So currently there are no strict guidelines with regards to imaging studies in patients with CID. However, imaging studies can be useful in demonstrating endothelial changes and disease activity. So patients with both CID and cardiovascular risk factors may undergo imaging to help detect subclinical atherosclerotic disease. So ultrasound can be useful in measuring carotid intimal thickness, which identifies early atherosclerosis, correlates with RA and SLE disease activity, and can demonstrate endothelial changes. And similarly, flow motion dilation of brachial artery can also demonstrate endothelial changes in patients with RA and SLE, which positively correlates with inflammatory markers, chronic steroid use, and clinical disease activity. And of course, as cardiologists, we'd love to use echo. I didn't put a picture of an echo in here because we all know what that looks like, but echo can obviously assess EF, can look for any wall motion abnormality in case the patient had either some sort of missed MI. It also looks at strain and diastolic dysfunction, which is more common, the more common type of heart failure in patients with RA. And then other studies or other imaging studies, so coronary artery calcification scores on CT, so those similarly correlated with systemic inflammation in RA patients. It's worth noting that in post-mortem analysis, patients with RA were twice more likely to have unstable atherosclerotic plaques than non-RA patients, despite having similar total plaque burden. So this suggests that chronic inflammation may impact plaque stability. In the future, we might be able to use PET, MRI, and SPECT. These imaging modalities might have a role in assessing plaque stability. So our role for caring for these patients with chronic inflammatory diseases. The key factors in mitigating cardiovascular disease in these patients are aggressive management of traditional risk factors and optimization of anti-inflammatory and immunotherapy for optimal disease control. We saw that patients who are not controlled, who do not have great control over their systemic inflammation, tend to do poorly. But this is easier said than done given all the things we discussed earlier. So the paradoxical responses, the medication dilemmas, no validated risk calculators, and the need for more research on this topic in general to help define subgroups and what the nuances between the different inflammatory diseases. So patients with CID should receive individualized risk assessment and treatment plans. Providers really need to aim at modifying the low-hanging fruit modifiable risk factors, so smoking cessation. So even though, like obesity or BMI had some paradoxical effects, smoking doesn't help anybody. So, really working on things like smoking cessation, really honing in on exercise and blood pressure control. And then when we see these patients, we should check lipids, LP, little a, A1C, CMP, ESR and CRP to assess for their current level of inflammation, EKG to assess for potential unrecognized MI, and of course echo to look for any wall motion abnormality and evidence of heart failure. So combined subspecialty clinics are emerging among a variety of subspecialties, and they serve highly complex patient or high-risk patients, such as oncology, geriatrics, and OB. A cardio-rheumatology clinic would allow for these patients to have, better or more comprehensive care, and it allows for a shared space between rheumatologists and cardiologists that can have close collaboration. Having a dedicated cardio room pharmacist would be really useful, given that both subspecialties prescribe a variety of medications, many with drug interactions and severe side effects. A specialized social worker would be a valuable resource to these patients, since they often require specialized home health services, specialized equipment, and a lot of them need help with paperwork. There's a lot of paperwork involved with disability. And also, it's much easier for patients to go to one established clinic to get their care, and it improves their ability to get care in a timely fashion. So, imagine the rheumatologist having to put out the cardiology referral. It takes them a while to get into cardiology clinic. They have a flat tire, they no show with their first appointment, and then it takes them that much longer to get in, and then they see that patient, they wait till the next room visit for that rheumatologist to read that cardiology note. Wouldn't it be much easier and nicer to have a cardiologist and the rheumatologist sitting side by side in a dictation room, and they can actually speak about the patient and talk about a care plan. So that's another benefit of these these combined specialty clinics, is that you work side by side with the different subspecialties, and you can really discuss complex patients. Currently, we don't have a specialized cardio-rheumatology clinic, but Dr. Izzy Adenzo, who's in the back, serves as our cardio-rheum specialist. So I have been referring patients that I've met inpatient with rheumatologic conditions to her. And they have much appreciation, because I think with a lot of these chronic diseases, patients really identify with their chronic diseases, and it becomes a part of them, especially because a lot of these things are diagnosed at an earlier age. And so when they hear that there's a special cardiologist that will care for them and can see them in the light of having their rheumatologic disorders, they're really grateful for that. That's all I have for today. So there's my summary. I think I hit over the main topics over and over again, but I'll leave time for questions. Thank you, guys.
Thank you, Bianca. I guess based on the fact you didn't cover it, probably sort of answers the questions, but I thought the part about the paradoxical lipid thing was actually interesting. I didn't really know much, if anything, about that, but sort of my question stems off that. Statin therapy in this specific subgroup, and efficacy or lack thereof. Has anyone looked at that, and sort of the thoughts on statins at an early age?
So there isn't. So the research needs to be done. There haven't been solid trials done on statin therapy in this population. But the current recommendations are, putting people on statins and treating for the hyperlipidemia.
So I guess then my follow-up question would be, as you mentioned, that the risk of these patients is underestimated by our traditional, and then how would you determine that in someone with this? How would you correct? I mean, you mentioned the sort of calculators that have been developed but maybe not validated at this point. The other calculators that use that. So how would you, in your practice, and maybe Ijeoma can comment on this, someone who otherwise would be well below 7.5%, but maybe does have active known lupus or rheumatoid arthritis and seropositive, et cetera. How would you account for that in your clinical practice?
So I would definitely hone in on the things that, like I said, the modifiable risk factors that we know don't help anybody. So they should exercise, hone in on smoking cessation, making sure their blood pressures are elevated. As far as weight and lipids go, because they're that paradoxical effect, I would also take into account their disease activity and try to figure out, is their weight low? Or are they losing weight because they're exercising and following this healthy lifestyle that I'm prescribing for them, or is it because they have inflammatory, like their disease is not well controlled? And that's in the case where it'd be nice to be able to speak with a rheumatologist to sort of get an assessment from that and be able to augment their rheum medications to better control that disease. So I guess it depends on how well the patient's doing from a rheumatologic standpoint, is how I would look at that. I don't know if Dr. Izzy Adenzo, do you have anything else to add?
Yeah, in this patient population, I tend to use coronary calcium scoring quite frequently because it helps to further risk stratify and gives me more of justification if I feel like statin use is indicated. Because most of these patients tend to be very young, during childbearing age, so it's not something where we can just easily say because they have lupus, because they have RA, that we would just immediately put them on a statin. So just being cautious with that, and so at least if I have evidence that they're in the 75th percentile or greater, or coronary calcium score greater than 100, then I have more of an indication to put them on a statin. Most of my time is really spent during that visit with sort of increasing awareness. You made a good point about this, about the underdiagnosis of hypertension and even hyperlipidemia. So I spend a lot of time increasing awareness just with the patient themselves about their risk for cardiovascular disease and why it's important to try to modify those risks.
Dr. Sherman has a question from Beyond. It's not really a question. Well, yeah, I guess it is a question. Any cardiovascular help with new anti-inflammatory drugs?
I'll let Dr. Zidenzo talk about this.
We know that methotrexate, like you said, which has been around forever, has been known to decrease cardiovascular mortality. Who've had CIMT testing, they found that patients who were on methotrexate, that after about 1 year, the CIMT and the flow media dilatation actually improved. As far as the newer drugs, azathioprine also seems to not have any increased cardiovascular risk, I will say. Nothing thus far that seems to improve the cardiovascular, the lipid profile. But I think there are certainly more drugs on the horizon and more research that is investigative in that area.
Thank you, guys.
The preceding program is copyrighted by Emory University.